أولا السلام عليكم ورحمة الله ومساء الخير عليكم جميعا. طبعا أولا أتشرف أني أكون موجود اليوم بهذا المؤتمر السادس للجمعية اليمنية. وتشرفي طبعا أولا يعتبر هذا أهم ميتنج بالنسبة لي أنا، طبعا يعني حضرت كثير من الميتينجز ولكن هذا له طعم خاص كوني أشارك مع زملائي من بلدي العزيز اليمن. نتمنى إن شاء الله الأمور تصير إلى خير بإذن الله. So in English, I would like to thank Yemen Ophthalmic Society for invitation us, MEOM Academy, to present this session. And today we are having a very eminent speaker from different parts of the world representing MEOM in this session, and we are happy to be participate in this conference. We are going to have two parts of this session. With the first one, it will be medical retina session, and we are having Dr. Fahad Kuhail and Dr. Majdi Musa. And the second one, it will be a surgical retina session, and it will be Awadallah, he will introduce the other speakers, but I can go now through all the speakers in general. Can you just, yes. So we are having Dr. Fahad, all of you. He is a consultant ophthalmologist surgeon, medical retina and uveitis specialist. He is now working in Mofield Eye Hospital in Dubai. My dear friends, Dr. Majdi Musa, Professor of Ophthalmology and Veterinary Consultant, Faculty of Medicine, Tanta University, Egypt. We are also proud to have today in surgical part, Dr. Ahmed Salam is Associate Professor, Retina and Uveitis, Director. He is Uveitis Service, Jones Eye Institute, University of Arkansas for Medical Science, Arkansas, USA. Also, my dear friends, Dr. Mohammed Al Amri, Professor of Ophthalmology, Cairo University, Egypt, Consultant Ophthalmologist, Veterinary Surgeon, and he is now before, I think, Maghrabi Hospital in Egypt. Can you go up, please? Also, we are having our dearest friend from Pakistan. It's a pleasure to be with us, Professor Hussein Haqqan. He is a Professor of Ophthalmology, Department of Ophthalmology, Lahore General Hospital, Amir Uddin Medical College. He is Postgraduate Medical Institute, Lahore, Pakistan, Veterinary Surgeon, President of Pakistan Veterinary Society. My dearest friend from the last part of the world, in the other side of the world, would like to welcome him and thanks him for being with us, Dr. George Rukha, and he's MD, PhD. He is a president of Retina Eye Institute. He is General Secretary of CBO, Brazil Council of Ophthalmology, specialty for retina and vitreous surgical and retinal. He is also a chair of the Retina Eye Institute. After introducing all, so we can start with our first speaker, Dr. Majdi Musa, and we will have a panel discussion about diabetic macular edema. Dr. Majdi, the mic with you, please. Dr. Majdi, if you can hear me, can you share your screen?
Yes, I
please?
can hear. I will share my screen. Sorry, I went out again. Sounds like it's a bad connection here. Can you see my screen now?
Yes. From Yemen, I want just to confirm everything is okay. You can hear us and everything is okay.
كل شيء تمام.
Okay, please, we can go ahead. So if you don't mind, Mahfoud, if you keep the mic with you, so if there is any interruption and question from anyone, in the
خلاص تمام.
can...
اوكي اذا في اي شيء ابلغك انا.
Okay. Dr. Majdi, please.
Shall I start? Thank you. Thank you, Dr.
Yeah,
Mohammed,
please.
for the invitation, and I'm glad to be there with the Yemeni Ophthalmological Society, though I wished I'd be there in person, but probably next time. My presentation today is diabetic macular edema. In spite of all we know about macular edema, it's still a challenge. So the challenge sometimes it's if you face a case with a visual acuity, what would you do? Would you keep injecting or follow up this patient? And sometimes you get to be successful or no? Then about
I don't know, Dr. Majdi, we are having, from my side, I cannot hear you very well. It's okay from you, Dr. Fahad?
give one injection and then do PRN.
There is difficulty hearing him as well. Yeah.
No,
I would suggest that he stop his video.
Can you stop the video? Can you stop the video, Dr. Majdi, because the voice is interrupted.
Speak about
Dr. Mahfouz, can you also from your side is hearing Dr. Majdi, or there is an interruption of the voice?
There is interruption.
There is, okay. Dr. Majdi, if you can hear me. Dr. Majdi. Dr. Majdi. Okay, can you?
يا مبارك خلينا نطفوا هذه هلكتنا. المكيف هذا طفي او المروحه. طب طفي الله يحفظك. ليش؟ طيب قول له يطفي قد هلكنا. روح مرضى.
I was muted. I'm sorry. Okay. Can you hear me now?
يطفي التكييف.
We can hear you, Dr. Majdi. Okay. Can you start from the first case? Okay. Dr. Mahfouz, you can hear Dr. Majdi now?
Yes, you can hear him.
Okay. I just stopped the video because of the streaming. Okay.
Okay. So please.
So this is my first presentation is a case of 6/9 plus vision with the center involved with diabetic macular edema with the cyst in the fovea. The patient is not complaining and he was discovered accidentally. And this is the color fundus, the OCT, and the central subfield thickness. In cases like this, up till now, we still have like a challenge. Should we treat these cases? Should we follow up these cases? And how is the regimen in follow-up? How long we can bring the patient in? If any of the panelists can want to share their experience with me before I show you what I did, I will be glad.
From my side, if you want my opinion, Dr. Majdi, I think we have to first advise the patient to control blood sugar. This is my way. I mean, it is a diabetic patient, so control blood sugar for 1 month and repeat again the OCT and see what is going on.
Thank you. Any other opinions?
Fahad? Fahad, mute yourself. Unmute. You are mute.
In my opinion, I would, if the vision is good and the patient's not particularly symptomatic, I would observe initially, but explain to the patient that they need to be seen on an 8-weekly basis. And if I see a decline and the vision goes below 6/12 and there's progression in the diabetic macular edema, then I might treat. And that's because I might be able to avoid treatment in this patient potentially by just observing, because this may resolve by itself as well.
Thank you, Fahad. Thank you, Mohammed, for the comment. And this is what I did. I just observed and monthly, as Fahad said, and is stable. Vision is improving 6/9 plus again, and the cyst is going away, and the patient was controlled from the beginning. So sometimes if you face a patient with a very good vision, you can only observe in these cases. But it is not always the same, because he's another patient who came with 6/9 vision, and I did observe, but unfortunately, 4 weeks later, vision dropped to 6/12, and cyst involved the fovea more, hard excess in the fovea, and hyperreflective foci, and the patient came with a drop of vision. So this is another thing to highlight. You can observe, but it has to monthly, every 4 weeks. If the patient is not coming back, or the patient cannot be obliged to the regimen up, or he's from far away and he cannot stay close to you, you should start treating this patient. And this patient was followed every 4 weeks, and he came with a recurrent macular edema or progressive macular edema, and he was treated by intravitreal anti-VEGF injection, and the vision came back to 6/9, and the patient was regaining vision. So in these cases, observation is an option, treatment is an option, but observation has to be every 4 weeks, as we said. If the patient cannot comply to that, he has to be treated. Sometimes we do laser for this patient. Which patient is eligible for laser? Some patients had center involved, yes, cysts in the fovea, and we have a fluorescein angiography showing where is the leakage. We can see sarcinic lesions in the parafoveal area, and we can treat this patient by laser patient. It's another option, but you have to see the leaking points. You have to do focal laser. There is nothing called grid anymore. And this patient sometimes regain vision without any injection. And this post laser 2 months, and it's regressing after good focal laser photocoagulation. So this is another option in treatment. However, focal laser, as I said, it can work, especially if you have a localized sarcinic lesion where the source of leak can be identified by fluorescein angiography. But the point is, does observation or intravitreal injection or laser prevent the recurrence? Unfortunately, no. This is 3 months post-laser, but 3 months later, the patient developed cystoid macular edema with sensory attachment. So there is no solid treatment for these patients, and we have to monitor these patients and to start injecting this patient once the treatment regimen failed, like observation, like laser photocoagulation, even intravitreal injection. We all know sometimes we inject and we have recurrence. So why we have a challenge in this case? Because we used not to know what to do with patients with 6/6, because all the studies, Rise and Ride, Vivid and Vista, Protocol INT, they were including patients with 6/12 vision or less. But patients with 6/6 vision were not including unless recently in Protocol V, where they said that at 2 years follow-up, the following up the patient with center involving with 6/9 or 6/6 vision, the 3 categories are the same. If you observe or you laser photocoagulation or you inject, the 3 of them are, so the end results, but with the compliance. Second thing, laser is an option with a leaking source, and injection is an option if the patient cannot show up in the follow-up schedule. So as we said, Protocol V summary in eyes with center involving diabetic macular edema, vision 6/9 or better, there was no significant difference in visual loss after 2 years. And intravitreal injection, 16%, laser photocoagulation, 17%, and observation. This is the net result after 2 years. The 3 categories has almost the same result. But if visual acuity worsened at any means, 5 letters or more, or patient became symptomatic, at any point, intravitreal injection should be started. We should not observe with the vision deteriorating. We should not observe if the laser is not effective after 3 months. We should not observe if the intravitreal injection has failed. So in conclusion, 6/9 vision, close observation is still an option, unless, especially if the patient can comply, and patient observation group who were later started on anti-VEGF aflibercept had the same number of injections that the patient treated with aflibercept from the beginning. So you should not hurry for the injection. Wait until the edema progress, and then you can inject. And in the protocol, they showed that most eye did not receive injection, but 3/4 of the laser group did not need any injection. 2/3 of the observation group did not need any injection at 2 years. So injection of patient will be more burden of them, and it will give us 65 to 75% of patients with unnecessary injection. So we can avoid the injection hazard by observation or laser photocoagulation. Let me move to the second part. It's cystoid macular edema with vitreoretinal interface abnormality. What is the abnormalities we meet at the vitreoretinal interface? Sometimes it takes 7 to 16% of eye with diabetic macular edema having only vitreomacular adhesion. They're having definite vitreomacular traction and posterior traction, or they're having tangential traction by epiretinal membrane. So the International Vitreomacular Traction Study Group classification of vitreomacular adhesion, they classified this, that the system will support the systemic diagnosis and management of cases with diabetic macular edema. Let's go to a challenging case. Look at this case. This is a vitreomacular adhesion with cystoid macular edema. Is there any absolute contraindication for intravitreal injection in these cases? And which lesion should be injected, or any preference for anti-VEGF? I'm opening that for discussion. Dr. Fahd or Dr. Mohammed, can you give me your opinion in these cases?
But I need another photo for this patient. Is if it is just a very sharp, sometimes we can inject in the beginning and maybe it will be separated after injection. But if it is wide, then if it is long and the adhesion is more wider on the surface of the
broad, you mean broad adhesion?
Yeah, broader. Then it will be. I think it's a surgical intervention rather than a medical intervention. Dr. Fahd or Ahmed, anyone of you?
Yeah, this is a really good point. I agree with you, Dr. Mohammed. I think if there's a more broad adhesion, then it's not that anti-VEGF wouldn't work, but it's less likely to be efficacious, and that you say you have to think about surgery. With this one here, I don't know if it's actually vitreomacular adhesion or whether because of the very central edema causing the foveal elevation, it's just pushing the hyaloid face up. So there's no actual traction here. And actually there wouldn't be a contraindication, in my opinion, to giving an anti-VEGF therapy and seeing how the patient will benefit from that. And then sometimes what you find is if it resolves, then you've done a good job. If there is traction there, then as it gets, you'll be able to see it better because the edema will get better, but you'll see this hyaloid face tugging on that area, and then you've highlighted the vitreomacular adhesion element to the macular edema.
Dr.
I can't agree anymore.
Opinion of one of the surgeon, either Abdullah or George or
I think the inferior photo shows clearly that it's not just it's a VMT, it's a vitreomacular traction. It's not just adhesion or so. So I guess we have to go with either vitrectomy or if you have jetria, you may also try to relieve it with the jetria. I would go for surgery right away, or pneumatic release of this adhesion.
Thank you, Dr. Mohammed. This is a very good point. As you said, the broad adhesion and the vitreomacular traction is completely different from vitreomacular adhesion. But as we said, broad adhesion in the literature should not be treated with intravitreal injection. But if it's a narrow adhesion, there is no much traction, we still can do intravitreal injection. So this is the case which was up there. And after one intravitreal injection, we can see complete separation of the posterior hyaloid, regression of the macular edema, which means that there is no contraindication when there is a very fine vitreomacular adhesion and there is no traction. Here's another example of vitreomacular adhesion. And again, it's only attached to the top of the cystoid edema, and injection in these cases is not hazardous and it can mechanically separate the posterior hyaloid. But in the contrary, if we have a broad adhesion like this and misunderstanding or misreading of the OCT with injection and laser photocoagulation can lead to iatrogenic macular hole. So again, we have to look at the different line scans. If there is a broad adhesion, we should not keep injecting these patients. If there is a minimal adhesion or just adhesion to the tip of the fovea with a very narrow adhesion, there is no much traction. And again, I can give you a very good tip. Inject once and see what's going on. If you can see that after one or two injections, there is no separation, it means that the adhesion is strong, even if it's a small adhesion. But if it's a broad from the beginning, the iatrogenic break is a must in these cases, and we should not inject these cases. So again, intravitreal anti-VEGF, as all the panelists agree, it's not contraindication with vitreomacular adhesion. On the contrary, it might separate the adhesion mechanically, and partially detached and thickened posterior hyaloid with broad adhesion is a relative contraindication. We should not keep injecting this patient. And evident vitreomacular traction, either tangential or anteroposterior, as Dr. Mohammed Al Amri said, we should go ahead for surgery from the beginning. Otherwise, we can end up in a disaster. Last part of my presentation in 5 minutes. This is a patient with center involving diabetic macular edema, and there is no doubt that intravitreal anti-VEGF is the standard of care in these cases. This case had a center involving diabetic macular edema, cyst in the fovea, parafoveal hard exudate, sensory detachment, and again, we can see here there is a vitreomacular adhesion, which is not a contraindication for injection. So in these cases, we all agree that injection is a must. And again, We can see here after 3 intravitreal anti-VEGF injection, restoration of foveal contour, 6/6 vision, even if there is a parafoveal hard axis or cystoid spaces. We are not aiming for this. We are aiming for the central subfield thickness. Vision is 6/6, and we can treat this patient. We can observe, or we can treat based on the treat and extend, or we can, PRN or treat and extend. But my question to the panelists is, do you always use a loading dose in diabetic macular edema, or you have a different regimen in these cases?
Okay. Fahad, yes, please.
Hi, guys. That's a really good question. I always give a loading dose only because for 2 reasons. A, that's where the clinical evidence supports that. You get your maximum gains of vision at 3 months, but also by using a loading dose, I'll be able to identify the non-responder, the diabetic patients who might need to use a steroid. So for me, unless cost is a real issue with the patient, I tend to give a loading dose before making a decision about do I extend or do I switch treatment. But so it would only be cost that would change my mind.
Okay.
If I had my choice, 3 loading doses.
Okay, Dr. Mohammed?
I think I will not add anything more than what Fahad said. Yes, we are giving a loading dose, but if the patient, it's according at this, what I mean, from the not from medical wise, but from if the patient is not able to have, or he cannot come every now and then, so sometimes we can give a PRN treatment rather than 3 loading doses.
As Fahad said, yes, loading doses is fine because most of the literature, but again, I will show you a couple of examples. Here is a patient who had 3 loading doses and there is no response. You can see that. And here is a patient who had 1 injection and a very good response. So again, still, diabetic macular edema, in the real life practice, sometimes you never know who is going to respond, who is not. Especially if the patient coming, in the acute phase, not long-standing diabetic macular edema or recurrent diabetic macular edema. But as we said, we are concerning about the patient. In Yemen, as in Egypt, sometimes the patient cannot afford 3 loading doses. So why not to start by 1? That's why I do my regimen, especially if the patient has no insurance, he's not covered. I give 1 and I do OCT, and if it responds, I do PRN after that. But if the patient is having 3 loading doses and is not responding, this is another issue we speak about in a minute. But again, it can be 3 loading doses if the patient is covered or he's not paying from his own pocket. But in countries like ours, maybe in Yemen, if the patient cannot afford, start 1 by 1. And sometimes you get astonished who will respond, who will not. But again, the majority of patients need the 3 loading doses, especially if they have cystoid edema, it's a long-standing edema, it's a chronic persistent diabetic macular edema. But again, do it 1 by 1 if the patient cannot afford to do that. So this is the definition of responder. This is a very good responder. After injection, the patient regained vision, 6/6 central subfield thickness is okay. But this takes us to what is the responder and what is the non-responder. Good responder means more than 40% reduction in the central subfield thickness. Moderate responder, 20 to 30%. These are from the literature. However, poor responder, less than 10%. Non-responder, no reduction or even progression of the central subfield thickness. And here's a patient who had 4 intravitreal anti-VEGF, and it was a very good response. This patient had 4 injections, and he regained the foveal contour, but again, the vision is not good because of the disrupted outer retinal layers. But let's come to a patient who had a 3 loading dose and minimal response. What should we do about that? This is a moderate responder, less than 10% reduction. Would you continue the same anti-VEGF, or you shift to another anti-VEGF, or you shift to steroid? Can I hear Dr. Fahad and Dr. Mohammed opinion quickly?
For me, I will shift immediately to steroid. I will not give any other
Same like Mohammed. Obviously, if I had a phakic patient and I had an alternative anti-VEGF like BioView or Frisimab, I might try it for only a couple of doses. And then if it's not working, I'm going to switch straight to steroid. But if you want to make it more straightforward, steroid may be a better option in this group of patients.
But it used to be in the literature that sometimes continue the same anti-VEGF might give a response in 5 to 10% of cases. Sometimes you can continue injection. This is nothing wrong about that. And sometimes you can shift, especially we have a lot of anti-VEGF in the market now. We have the Faricimab, we have the BioView, and in addition to Lucentis and Eylea. So again, we have a variety of anti-VEGF, and we all know that the standard of care is anti-VEGF. But this is anti-VEGF therapy, means that sometimes continuous injection might have a better response, and sometimes in the rise and ride that 9 to 10% of the treating patients with anti-VEGF had the delayed response after the 3 injection. But again, with the varieties of anti-VEGF we have now, we used to have only 2 anti-VEGFs. With the variety, we can shift to another anti-VEGF, and it might get response. And also in protocol I, they said the diabetic macular edema who have poor initial response to treatment may achieve clinically significant visual gain if continued treatment, and shift from one to another, as we can see here, might give a very good response from one anti-VEGF to another. Here's a case presenting with very poor response to Avastin, and I switch another diabetic macular edema after 3 loading dose. Switching to another anti-VEGF can give a very good response sometimes. So I switch after 3 to 4 injections, especially if there is no response at all, or if there is a progression. I should not wait for that. But sometimes, as we said, shifting to steroids might be hazardous because of the patient's cataract disease, glaucoma suspect, or any of these things. Shifting to another anti-VEGF might get a very good response. Here is another patient. I give 3 anti-VEGF, and you can see it's progressive. It's getting worse. So there is no mean that this patient should continue the same anti-VEGF. So again, shift to another anti-VEGF once showed that this patient is not a VEGF responder. He will never respond to any anti-VEGF, and steroids is a must in these cases. So again, shifting from one anti-VEGF to another, it's a good idea, but you should not keep 3 or 4 doses again. Once and see the response. If there is no response, steroid is still in the one of the good player in these cases. So when to switch to steroid, this is rapidly wrapping up. Switching to steroid, if you switch from one anti-VEGF to another, or in pseudophakic, you can switch directly to steroids. Patient contraindication to anti-VEGF, like epiretinal membrane, like this one, you can shift to steroid. And sometimes if the patient had a recent stroke while you are injecting anti-VEGF, you should not continue injecting anti-VEGF in these cases, and you should shift to steroids. And this is, steroids can do a magic in cases with epiretinal membrane, and you are not afraid of the tangential traction done by the anti-VEGF. So again, steroids still have a very good role in management of diabetic macular edema. And my take-home message is still intravitreal anti-VEGF is the main line of treatment in center involving diabetic macular edema. And anti-VEGF is not contraindicated with vitreomacular adhesion, and 3 loading dose, then PRN or treat and extend are the most favorable regimens. And in non-responders, you can switch once to one anti-VEGF. If there is no response, you can switch to steroid at the end. Thank you so much for your listening.
Thank you very much, Dr. Majdi, for this interesting cases, as usual. I have small just comment because Dr. Majdi, there is a different opinion regarding switching between different anti-VEGF. Maybe before the era of pralucizumab and faricizumab, we are, most of us, I think, we are not switching between another anti-VEGF. We are switching to steroid, especially directly from anti-VEGF from after the 3rd injection, especially if the patient is pseudophakic. But now, because of the new era of we are having a new strong medication like pralucizumab and faricizumab, I think we are now able to switch between the previous anti-VEGF, either Lucentis or Eylea, to a new molecules. This is my opinion regarding the in general. If there is any comment from Fahad or Majdi about this, just to do the final concluding about Dr. Majdi talk.
No additional comments. I really think you've wrapped it up very well, Mohammed. I think it's just an exciting time to be a retina specialist. We have a lot of multitude treatments. So I think the key is, anti-VEGF is your first line, but if it doesn't improve, that you make that switch quite early on to a steroid in order to maintain that visual function for the patient. Don't make a decision to switch too late.
That's right. Thank you. Thank you so much for these comments. And I think I delivered the message.
I have one more comment, Majdi, if you allow me, and maybe Hussein, he can participate on that because in Pakistan, they have a lot of experience. we are, I think in Yemen, they are having also problem to give injection that costs $1,000 every month or $2,000. So they are using also steroid, which is a very cheap one, not intravitreal, subtenuous. I don't know, Hussein, also I have heard about this one a lot when I was in Pakistan. Most of the people, they have do a study and they get a good result. I think we have to modify our treatment according to what is available and according our patient, how they are able to pay for that or not. So just to customize our treatment. Hussein, if you have any comment before we move to Hussein, Dr. Fahad.
Yes, I mean, when your patient is not responding, or when your patient needs a lot of anti-VEGF as in vein occlusion or other resistant cases, then mostly in Pakistan we switch over to suprachoroidal steroids, and it's doing good. That even one suprachoroidal injection is good enough for the patients who are having vein occlusion macular edema or diabetic macular edema. Even it stays for 2-3 months. So this is much cheaper version for if you cannot afford the anti-VEGF, or anti-VEGF is resistant in some cases. So you can switch in both scenarios.
Thank you for the comment.
Okay,
Thank you, Mr. Hussein.
Okay, we can now, Dr. Fahad, if you can go ahead, please.
Hi, good afternoon to my Yemeni colleagues. Again, thank you for Mohammed Al Amri for kindly inviting me and giving me this opportunity to participate with the Yemen Ophthalmology Society today in Aden. So obviously I'm born in the UK, but my origins are from the Yemen. So my parents are from Bala, which is not too far from Aden. I look forward to joining you, inshallah, sometime, inshallah, and I hope I can contribute to webinars with the Yemeni Ophthalmic Society in due course. Just very, very quickly, over about 10 minutes, I'm just going to talk about post-surgical uveitis and endophthalmitis. So in a post-operative patient, it's important to differentiate between infectious inflammation from non-infectious inflammation, as both can impact vision outcome if not addressed promptly and appropriately. So I'm talking about inflammation after cataract surgery or after, say, intravitreal injection. So the first main cause is that you've missed a uveitis, or you've done an operation, a cataract surgery on a uveitis patient, have not ensured you have good control of the uveitis. So any patient with a pre-existing uveitis can often develop an exacerbation of intraocular inflammation after surgery. So it's vital that in any uveitis patient with a cataract, that you only perform the cataract when it's visually significant, and make sure that you control the intraocular inflammation either with topical steroid or systemic steroid or local steroids, and it's quiet for at least 3 months prior to the surgery. If you have bent keratopathy, then by all means go ahead and remove that to improve the surgical view. And certainly in Dubai or in the UK, if I had a patient with uveitis, even if it was controlled and they had a posterior uveitis, I would give them a dose of intravenous corticosteroid, I don't know, about 500 to 700 milligrams as a one dose, but there's no harm in giving them high dose oral steroid, 1 milligram per kilogram, and you start that a few days before the surgery and taper it over 4 to 6 weeks. You must give it in an eye that's quiet, controlled, and you still, nevertheless, give them intensive topical steroid, but also oral steroid to ensure they don't get a flare with uveitis, spoiling that very good surgery that you've performed. Occasionally, the flare can be so severe that it be confused with an infectious endophthalmitis, but the hypopia and severe pain is rare in severe non-infectious uveitis that's been made worse by cataract surgery. This is a patient of mine back in the UK with tuberculous uveitis. As you can see, she has significant synecdoche and a cloudy lens. She was in a hurry for me to perform her cataract surgery, but I refused, and actually it took about 4 to 6 months to control her uveitis on a combination of anti-TB therapy and topical steroid. This was her OCT prior to cataract surgery, and her ocular inflammation was in remission. And so I prescribed a high-dose steroid postoperatively, tapered over 4 to 6 weeks. But despite that, she developed cystoid macular edema with a drop in vision, despite having a quiet eye and giving prophylactic oral steroid. So I gave the intravitreal Ozurdex the same day, but triamcinolone, either intravitreal or subtenon, would be very reasonable as well in this patient. And then I came across this particular paper which showed that giving steroid as an alternative to systemic steroid works as well as a prophylaxis in patients with uveitic cataract surgery. And what they did was they randomized eyes either to get intravitreal Ozurdex at the time of surgery or a course of systemic steroid. And all of these patients were uveitis patients who underwent cataract surgery and whose ocular inflammation was controlled for 3 months prior to surgery. And what they found was that intravitreal steroid was equal to systemic steroid as a prophylaxis. So this is what I did for her fellow eye. So for her fellow eye, instead of giving systemic steroid, I actually gave an intravitreal Ozurdex. And as you can see, we avoided a flare in her macular edema following cataract surgery. There's another condition called toptic anterior segment syndrome, which is an acute non-infectious inflammation of the anterior segment of the eye, and again is a complication of anterior segment eye surgery. It normally develops within 24 hours and is characterized by corneal edema from limbus to limbus, significant amount of inflammatory white cells within the anterior chamber. Very occasionally it can have a hypopyon, and it's thought to be related to contaminants from either inadequately sterile ophthalmic instruments, surgical equipment or supplies, or using irrigating solutions with abnormal pH or osmolarity. This is symptoms of TAS. The vision or loss tends to occur very quickly, within 12 to 48 hours from surgery. Pain ranges from mild to severe, with significant photophobia. There's an acute severe inflammatory reaction within the anterior chamber. Corneal edema extends from limbus to limbus, with either a dilated or irregular pupil, sometimes with hypopyon. This is the thing to help you distinguish between TAS and infectious endophthalmitis, that it has a good response to topical steroid drops. So if I saw a patient very quickly after cataract surgery with pain, with significant inflammation, the fundal view was good, I did an ultrasound and showed the vitreous was clear, then I might be thinking about TAS. I would keep the patient in my clinic, start them on half-hourly topical steroid, or get the nurse to instill topical steroids on a half-hourly basis, review the patient after 4 to 6 hours. If the inflammation was improving, their symptoms was improving, then this was TAS. This was non-infectious, and I would continue the patient on topical steroid and obviously monitor them very closely. But if there was no improvement or limited improvement, then I would have a low threshold to do a tap and inject and treat it as if it was an infectious endophthalmitis. Remember, I would have a good view to the back of the eye, or the B scan would be clear. If the B scan showed vitritis, even if you suspect TAS, you've got to have a low threshold or high index of suspicion for infectious endophthalmitis and treat the patient accordingly. So the treatment of TAS, the main treatment is prevention. So make sure you have good sterilization, cleaning practice at your surgical center, use appropriate balanced salt for intraocular use, and ensure any intracameral medication that you use is preservative-free. Once you've excluded an infectious etiology, start the patient on intensive topical steroid, as I said, every half an hour to an hour, and the patient should be closely monitored to make sure the inflammation is not worsening. Because if you're not sure it's TAS, then have a high index of suspicion and have a low threshold to treat as a postoperative endophthalmitis. And remember, if TAS is severe and you don't manage it well, it can lead to permanent damage, such as cystoid macular edema or a permanent dilated pupil. So you need to treat it aggressively and promptly. But this is the main theme of the talk, postoperative endophthalmitis, which is characterized by marked inflammation of intraocular fluids and tissues, leading to severe vision loss, even with prompt and appropriate treatment. And exogenous endophthalmitis occurs when infective agents enter the eye, typically from the ocular flora, following intraocular surgery. And it tends to be limited to the eye, and predisposing factors include like diabetes mellitus or preoperative treatments with immunosuppressive medications increases the risk of postoperative endophthalmitis. These are some of the other risk factors like blepharitis, conjunctivitis, lacrimal drainage obstruction, using contaminated eye drops, irrigating solutions, contact lens wear, PC rupture or vitreous loss because it prolongs the operation. And I had a low threshold in the UK to cancel patients if they had a conjunctivitis or a lacrimal drainage obstruction because of my concern about the increased risk of postoperative endophthalmitis. What you don't want is to take an eye with mild or moderate vision impairment because of the cataract and induce severe vision impairment because you were careless and they developed a postoperative endophthalmitis. What are the symptoms of endophthalmitis? It's a clinical diagnosis confirmed by laboratory tests, but it's a clinical diagnosis. And it's defined by the clinical history and the characteristic timing of symptoms and signs. And it tends to present within the first 6 weeks of surgery, but on average, it presents within 5 to 6 days, but it can range from anywhere between 1 to 30 days. And you're going to get acute vision loss, redness, pain, marked anterior chamber inflammation, hypopion, with possibly eyelid edema and vitreous inflammation. The differential includes TAS, retained lens fragment, flare-up of pre-existing uveitis. So you've got to keep this all in mind when you see a patient with where you suspect postoperative endophthalmitis. But the key treatment is tap and inject. And you can do this in a procedure room, in a clean room. I would give the patient subconjunctival anesthesia. And the things that you need is an eyelid speculum, povidone iodine preparation. And as you can see in the video, they're using a blue needle with a 5 ml syringe. And then you inject that 4 millimeters from the pars plana, from the limbus into the pars plana, mid-vitreous. So obviously it's a long needle, so you don't inject all the way in, just like a quarter of an inch into the eye. And then I aspirate. And I use a 5 ml syringe because it gives me the aspiration pause that I need to get a liquefied sample. And I tend to aspirate 0.3 mils and send that for microgram stain and culture and sensitivity to biomicrobiology. And prior to doing the tap and inject, I would also then prepare vancomycin and cefazolin at concentrations of 1 milligram in 0.1 mil and 2.25 milligrams for the cefazolin. And then I'll inject that again in the pars plana in separate syringes using and injected in other parts of the eye, again in the pars plana. So I might, for example, do the vitreous tap in the intertemporal quadrant, and then slightly adjacent to it, do one injection, 1 intravitreal antibiotic, and then the supratemporal quadrant might do the second intravitreal antibiotic. And if you take that 0.3 mils, inject 0.2 mils, the eye quickly reforms and you get normal pressure. And then I tend to treat the patient with systemic steroid following the injection. Obviously, if the patient has vision of light perception or worse, then it's likely the patient will need a vitrectomy. So if you're lucky enough to work in a unit where you have a VR surgeon, then by all means, it's reasonable to refer the patient for an urgent vitrectomy. However, if you're seeing the patient at another center where you don't have vitreoretinal services, then please do not neglect your duty for this patient. Before you refer them to the next facility, perform an immediate tap and inject. So take the vitreous sample, inject the antibiotics, start the steroid, then refer the patient to the VR surgeon to do a secondary procedure. But please treat these patients promptly. Do not neglect your duty. In conclusion, in the early vitrectomy study, the most important predictor of final vision outcome in patients with postoperative endophthalmitis was presenting visual acuity. But there are a proportion of patients who will do well with early treatment. So it's vital to treat promptly and urgently to improve the chances of vision improvement. If the presenting vision is light perception or worse, then refer for urgent vitrectomy, but do not neglect to perform a vitreous tap and inject so therapy is promptly initiated whilst you make that referral. Do not neglect your duty for that patient. And if you're considering TAS, or toxic anterior segment syndrome, then treat that patient aggressively with topical steroid. But if they do not improve within a few hours, have a low threshold to tap and inject if the clinical condition is not improving as expected. And please have, if you haven't done so already, have your protocols in order to make up the vancomycin and the cefazolin as and when you need, so that that is prepared before you do your tap and inject. And thank you very much.
Thank you very much, Fahad, for this excellent presentation, as usual. I don't know if there is any comment from our colleagues. I was waiting for Ahmed Salam. Maybe he will have some comment about his very specialized.
Yes, I have special interest in endophthalmitis treatment. I've had a great presentation. I think the message is important is that even in the best center in the world, until you set up for vitrectomy, it's going to be at least few hours. So really, I would strongly encourage treating those patients with intravitreal injection of antibiotics. And the dose you inject in the eye is really a very high dose that should look after the organism. It's called super MIC, super minimal inhibitory concentration dose. So even light perception eyes, if you cannot set up for vitrectomy now and then, I would inject those patients quickly. And they do very well. And vitrectomy surgery is a very difficult surgery in these cases, really, when the eye is hot.
Ahmad, what is the protocol usually you are doing?
Our protocol is to inject these patients, regardless of the vision, within 1 hour, and preferably within half an hour. We inject them anywhere. We don't take them to the operating room. They're already infected. So what we do is we get them in. We try a tap. If the tap comes negative, we don't worry about it, because if you think about it, most of those patients respond to empirical treatment. Then we inject vancomycin, 1 milligram, inject ceftazidime, 2.25 milligram, and then we just give them topical steroids, and we don't worry even about topical antibiotics. The main treatment of endophthalmitis, and I think that's the important message, is intravitreal antibiotics. And then we give them systemic steroids. And then very important to see what happens to them and make a decision whether they are improving, so no further injection, or they are not improving.
Ahmed, one question, and for Fahad also. Are you using an intravitreal steroid?
So the evidence is that if you look at the evidence, there's evidence that it works, it's beneficial. There's evidence it's not beneficial, not bad, and there's evidence it's bad. So there's mixed evidence. I think the short answer is do use them if you want, but do not use Kenalog, because of the risk of sterile inflammation. Then you're not sure what's happening. So use dexamethasone if you want. I think that's absolutely fine.
Yes, go ahead, final.
Yeah, no, just again, just to support Ahmed, have a low threshold to inject these patients. If you're not sure, the risk from intravitreal therapy or antibiotics is going to be very low. At the end of the day, you're potentially going to do benefits. In regards to dexamethasone, there's definite evidence to support that it works when it's bacterial endophthalmitis, but I've shifted away from it only because, if there's a small risk that it is a fungal endophthalmitis, although that tends not to present very, very quickly, and it is a much more delayed presentation. So I tend to just give systemic steroid because I feel it hastens the vision improvement, reduces the secondary effects of toxic inflammation on the retina. And I just think in my hands, it improves the outcome of these patients.
Thank you very much, Dr. Fahad and Dr. Ahmed. Is there any question, Dr. Mahfouz, from your side before we move to the next sessions, surgical? Or any comments?
حد عنده أي سؤال من الشباب هنا؟ تفضلي. في سؤال الآن؟
اوكي دكتور محفوظ معك.
عفوا. About congenital cataract, I don't know if you are interested in this or not. If there is rubella suspicious, is it wise to delay the operation till after 5 years old, or no? Because there is suspicious of highly reaction, because the rubella is inside the capsule in pediatric cataract.
Okay, can you, Fahad, did you get the questions?
Yeah, so I think the question is, and inshallah, sister, I've understood you correctly. So you've got a child with congenital rubella and now has a cataract in her eye. and she's young, and you're saying whether we should delay the surgery to the age of 3. From no, what I'm not is a pediatric ophthalmologist, but from my basic understanding, because of the high risk of amblyopia, that you'd probably want to do surgery on that case, because I don't think there's going to be any active rubella. You're not going to induce a flare of their uveitis because you've taken out their cataract. I'm confident by the time they're born that the rubella infection has settled down. However, if you, Professor Mahfouz has my WhatsApp number. If you want to share the specifics of your case, and I'll try and get you a more detailed answer, inshallah, with the specifics of your case. But I would say with congenital cataract, the early treatment is better to prevent amblyopia in those children.
Okay, I will share your number with her.
Thank you, Mahfouz.
Is there anyone who have any idea about that?
تفضل يا دكتور عادل.
Imam or George or anyone have Hussein?
في دكتور عادل عايز يسأل سؤال.
I think using from the intravitreal dexamethasone. I think that using from intravitreal dexamethasone is very important for the endophthalmic. A lot of the people will have spoke about that. We have the people speak about the using from the intravitreal dexamethasone at the fungal endophthalmitis, and it's very important for improving the endophthalmitis. This is number one. Number two is using from the visual acuity LB for the changing for the vitrectomy. I think it's come back for the studying about the 30 years ago, and the vitrectomy is changing now. I think you can change for the vitrectomy as with the better version from that.
Can I answer this? Maybe.
Yes, Salam, it's for you. It's obviously it's for you.
I mean, if you want, yeah. I just want to. So I think this is really a great question, and so we did a study recently because exactly what was said, that we are better surgeon now than before the endophthalmitis, than compared to the endophthalmitis vitrectomy study era. We have better equipments, we have better light, vitrectomy is a safe surgery. So we did a study from European data looking at, in the first report, we looked at what surgeons do, and exactly we found what said, that 75% of the retina physicians treat endophthalmitis as a first line of treatment by surgery. Then in the second report, and that was really what we are doing. In the second report, we looked at the difference between the two groups, those who had early surgery and those who did not. And there was no difference. Actually, on the contrary, we found worse trends with vitrectomy. For those of us who do vitrectomy surgery, this is a very difficult surgery. And if you have one break, you lost the eye. Where actually with intravitreal injection treatment, more than 90% of the eyes are sterile after one injection. So I think, yes, I agree with you, but we don't see this. And all the big studies show that vitrectomy does not add much benefit.
السلام عليكم دكتور أحمد سلام معك دكتور نبيل كيف حالك إن شاء الله بخير
أهلا إزاي الصحة أهلا وسهلا
منور دكتور عمر
ربنا يخلي حضرتك
طبعا من خلال تجربتنا في اليمن الحالات توصل متأخرة وصاير يعني بالجريد 3 up to 4 endophthalmitis claudicornea الممbrane في الانتيرو chamber بسكان fall of the endophthalmitis. So first choice in Yemen in these cases is operation if the patient light perception and more. But if the patient came at the first day office hours, we try to start before we know if it is endogenic or exogenic. If it is endogenic, just about the cause of the endogenic endophthalmitis. If it is trauma or another things like children, needling endophthalmitis is very high in Yemen. So start with injection. It's give time to do operation because it's still worsening. So the patient came, we give him antibiotics, drops, and also IV antibiotics, and we give him the decision. I will do operation for your patient because if it is worse than 1 day. Second day and follow up. If it is worse, I do operation. Early operation, ophthalmitis, give the best result. This is my small practical opinion, and we are working more than 20 years in vitro-retina surgery. What do you think about that?
Look, I think this is great, but one point I think is very important. The main treatment of endophthalmitis is not, even if you're going to do surgery, is not surgery. The main treatment of endophthalmitis is intravitreal injection. So I think, you know, those patients given drops, that's fine. These are adjuvant, but it's mainly the injection. So giving injection then operating is fine. But I think it takes time to get surgery prepared for. And every 20 minutes, the organisms are multiplying. So I would say give it antibiotics first, then after that, whatever you see is fine. And really, no, I value your experience. This is great.
Just to comment, so endogenous endophthalmitis, you know, it's difficult to educate patients. You know, at the end of the day, if a patient develops, you know, if a patient develops, is lucky enough to develop endogenous endophthalmitis, then they'll be ignorant about the signs and they will come to you at a late presentation. But what I would argue is if you're operating on patients, either doing cataract surgery or intravitreal injections, it is important that you explain to them what are the symptoms and signs of endophthalmitis, what are the things they need to look out for, and give them contacts so they can present to you quickly. So the patient, you can't, if patients come to advance, you know, that you've not operated on, then, you know, that's fine. But the patient that you operate on, it's vital that you give them that education so that they present to you immediately, so that they come in a timely fashion, and you can still offer them individual injections. But I would say even with a late presentation, always start with intravitreal therapy and then go to surgery.
Yes. So
we have the last comment from Awdallah, please, because we are running. I think.
Just a very small comment. I would say it in Arabic. هو الميكروب بيتكاثر exponentially مع الوقت. فهو يعني by the time المريض هيبقى referred لفيتريوريتينال فاسيلتي، والفاسيلتي دهيت يعني حتى لو next door، يعني لو جنب البيت، هو الافضل انه هو يتحقن immediately and then we think about السيرجري. ليه؟ لان الميكروب كل ما يتساب لمده دقيقه او 5 دقائق او 10 دقائق بيتكاثر exponentially. يعني الاربعه بيبقوا 8 وال8 16 وال16 32 and so forth. فهي الفكره مش ان surgery gives better results than injection او injections give better. هي الفكره في اللوجيستكس to transfer the patient to a good surgeon. يعني this is the real problem. So to be pragmatic, يعني you just go for the safe thing. You just inject, you control التكاثر بتاع الميكروب، وبعد كده if there is a residual opacities in the media, you can do surgery. This is my point.
Can we have the first comment from Dr. Yeah, please go ahead.
شكرا يا لقاء صاحب.
I think we need to finish because we run a lot behind the time, so we can move to the surgical part. And I will forward the mic to Dr. Awdallah. I think the first presenter, it will be Dr. Hussein, please. Hussein, it's okay now, the connection with you?
Yes.
So you can share your screen, please, and you can start.
Yes, is it visible there?
Yes.
From our side here, I think, yes. From Yemen, okay? Mahfoud?
Yes, yes.
Okay.
So, should I start?
Please.
Yes. So thank you, MEOM, and thank you, Yemeni Ophthalmological Society, for the kind invitation. I am Professor Hussain Ahmad Hakan. I am basically a retinal surgeon and solely practicing as a retinal surgeon. So I've been assigned the topic about the macular epiretinal membrane surgical techniques. So I will go very quickly and briefly about this pathology because it has nothing much. What is macular epiretinal membrane? It's avascular cellular proliferation and connective tissue deposition above the internal limiting membrane. And here you can see it can make a pucker, it can make a membrane and thicken as much the proliferation is there. It depends on the pathology that has caused the epiretinal membrane. Mostly it is idiopathic, but maybe the other pathology can cause such like this epiretinal membrane. You can get from this membrane from this thickened to the very light thickened membrane. So here you can see a patient with the epiretinal membrane, and he has got with the red arrows. And the similar here you can see the patient with the epiretinal membrane, and he has got the cystoid macular edema. So epiretinal membrane cause many visual dysfunction due to the many sequences. So what is the etiology of this disease? The etiology is usually idiopathic. I told it's a trauma, intraocular surgery, any surgery can do, mostly the retinal surgery, post-macular laser or retinal laser, in diabetic retinopathy, macular vein occlusion, after the macular edema, and mostly after the ocular inflammation. What is the pathophysiology? Basically, the cells get the proliferation over the internal limiting membrane through the posterior detached, highlight. A fibrocellular proliferation over the internal limiting membrane and characterize the epiretinal membrane. The initiating event is an idiopathic epiretinal membrane, the posterior vitreous detached. These cells later transdifferentiate into the fibroblast-like cells to form a cellophane-like membrane. So this is basically a cellophane-like membrane that due to the fibroblasts of the cells. The issue is why to peel the ERM. There are many objectives to get why to peel the ERM. It's just to improve the visual acuity, to improve the metamorphopsia and diplopia, anatomically release the traction on the macula, in advanced cases to prevent the further complications. What are the indications of epiretinal membrane peeling? Symptomatic decrease in visual acuity that is less than 20/70. A visible epiretinal membrane with the stria, epiretinal membrane with the macular thickening and edema. Best corrected visual better than 20/40, but significant symptoms like metamorphopsia and diplopia. So a macular pucker after retinal detachment surgery. These are the basic indications, but it all depends on the different scenario and how the patient's other eyes behaving and how what are the cause of this disease and how much benefit you can get from the epiretinal membrane peel in these cases. So preoperative assessment, as I've already talking about, that it is very important to have a preoperative assessment whether this visual epiretinal membrane is visually significant, whether it is causing macular edema, whether it is decreasing the vision, whether it is causing the metamorphopsia or any other thing. So main is the symptoms that the patient is encountering will depend on the surgical management of epiretinal membrane. If he has a patient having a significant metamorphopsia, then even with the good vision, you have to go for the surgery. So usually what I do pars plana vitrectomy with epiretinal membrane peel and ILM peel, and depending on the basic pathology, I give the endotamponade depending on the basic pathology. But solely in all the cases, I do for the epiretinal membrane and ILM peel. I don't peel the ERM only, I do peel the ILM in all the cases. So here I will share a few surgical videos of mine. So here is the case. Here you can see the epiretinal membrane. It's a thin one, but the fold is there. I am doing with a 23 gauge vitrectomy system, doing the core vitrectomy in this case. and then injecting the triamcinolone to stain the posterior highlight, because detaching the posterior highlight is very significant and important in this case, because most of the time there is a taut posterior highlight that may bring the epiretinal membrane with it. So dealing with the posterior detachment in these cases is very important. So I stain the posterior highlight and then detach the posterior highlight with the stained Canacord. Then I injected the brilliant blue green, and then I am stain the blue green, and here I am just starting to peel the ILM, and with the ILM I will just peel off the epiretinal membrane. As you can see here, the epiretinal membrane is over the ILM. So in one go I am peeling the ILM and epiretinal membrane. So ERM has a little brittle character than the internal limiting membrane. So in one go, you can peel the ILM and epiretinal membrane both. But I will share the other videos where I have different techniques where I peel the ERM separately and ILM separately. But if you have a very thin epiretinal membrane, then you can go easily with the ILM peel only, and it will separate the epiretinal membrane lying over it very easily. So here I am just peeling the ILM with the 23 gauge ILM forceps, and you can see that there is no ILM in the macular area. I tried to peel the ILM from arcade to arcade, so and you can get rid the epiretinal membrane along with the ILM here in such cases. This is a simple case, so I will just switch to the another case. This is 23 gauge system patient with the pseudophakic eye. I injected did the core vitrectomy, did the posterior highlight detachment, and then I am peeling the stained with the brilliant blue green. And here I am peeling the epiretinal membrane separately. It looks like taut posterior highlight, but it is the epiretinal membrane. Then after peeling the epiretinal membrane from all over the macular area, then I am start peeling the ILM. So this is a little bit different technique here. I am peeling the epiretinal membrane first and then peeling the ILM. In previous case I've showed, because the epiretinal membrane was very thin, so I just start peeling the ILM, so epiretinal membrane came with that peel in those cases. So it depends how much thickened the epiretinal membrane it is and how much significantly it is taut. So you can choose any technique according to your case. So I first peel the epiretinal membrane, and then I am peeling the ILM with the ILM forceps. So these are the basic surgical techniques that I'm showing here. So you can do it easily and get rid of the epiretinal membrane. Here I'm leaving the eye with the air at the end of the procedure. Here you can see the patient, he has a VMT, he has epiretinal membrane. So I will show you how to deal with these cases who has the epiretinal membrane and VMT and distortion. So here you can see the macular area. I am doing the core vitrectomy first, and then similarly I invariably inject the triamcinolone in all the eyes who has got the vitreous to detach the posterior highlight and get the full idea that there is no posterior highlight over the macular area. So here you can see the taut posterior highlight is there. It's not easy to detect the posterior vitreous from the macular area. So it is coming, but it's not coming very easily. So the induction of PVD was not very easy in these cases. Sometimes when you have a VMT epiretinal membrane and say similar scenario. So after doing this, I am injecting the brilliant blue green. I usually inject the BBG under air so I can get a good stain. Here you can see the epiretinal membrane is stained with the brilliant blue green. So I am peeling in this case the epiretinal membrane separately because it is very thick and taut. So I am trying to grasp the ILM with it, but I was not much successful in this case. So I try to peel the ERM first, so you can see how thickened and taut the epiretinal membrane is in this case over the macular area. So sometimes you encounter very small epiretinal membrane that are easily to peel, and here you can see a large area of epiretinal membrane, almost like the posterior highlight, because this patient has the vitreomacular traction. He has got the epiretinal membrane, and that's why here you can see I have detach the posterior highlight, detach the epiretinal membrane, and then I will cut this thickened epiretinal membrane even with the cutters. That's not was easy to remove these membranes with the and grasping, ILM forceps. So at the end of the surgery, I'm just chewing it with the 23 gauge cutter. So here you can see at the end of the surgery, there is a patchy stain of few stains of the ILM. So sometimes it stays there, but it's not much harm because most of the ILM is gone with these epiretinal membrane. Here it shows the post-operative OCT if you compare with the pre-operative OCT. So what are the expected outcomes in these cases? 75% chances of improvement of symptoms, 20% chances of no improvement of symptoms, 5% chances of worsening of symptoms. That's very important. So because when you are going to going for epiretinal membrane peel, it's very important to assess the preoperative VN, what you are gaining from the surgery, whether it may cause decrease in the VN, whether symptoms are so significant that it would help, the surgery would help in improvement of symptoms. So sometimes it's very tricky decision, but you have to be very careful dealing with the patients who have a very good VN, mean 612 and 618 VN, and you are going to peel the epiretinal membrane, but you should make sure to peel the ILM with these cases too, because you cannot leave the ILM, but you should know that whether your surgery is going to improve the VN and whether your surgery is going to remove the metamorphopsia. If you have any doubt in it, so revisit your diagnosis before going for these surgeries. So thank you so much. I was a bit quick, and if you have any question, I am here. So I have finished my talk at this slide. Thank you.
Thank you, Dr. Hussein, for a very nice presentation, nice videos. Is any of the panelists want to comment or any questions? في أي أسئلة من الحضور سادة الحضور؟ I think the ongoing debate whether to peel ILM with ERM or not, and is it worth to peel it with some of the complications of ILM peeling? What do you think, Dr. Salam? Then we'll ask Dr. George about the same question. Do you peel ILM with all cases?
No, I peel it only if it comes out. Otherwise, I try to do the minimum, and I think it's not without the risk. We see Donfil, and we see also like retinal touches. So if it comes out with it, I think that's fine. If it doesn't come out, because the evidence shows, well, maybe it decreased the recurrence, but it does not increase the vision.
George, what do you think about this?
I agree with Dr. Salam. I don't peel every case. Sometimes if the retina is so distorted, I just remove the emittent membrane to make the retina more flexible. I try to indicate surgery very early, because some paper has shown that if you postpone too much, you never get good vision. And then if the patient has metamorphopsia or diplopia, anything, I try to push him to operate, because I do know that the surgery gonna help a lot. And if you spend something like waiting for 2200 vision, maybe never get much less than 1 or 2 lines improvement. But this bad case, I try to remove the internal emittent membrane, but it's not always, very few cases.
Yes, I do agree with you, George. And I think also patient education before surgery and the expectations are really important. What do you think, Dr. Hussein, about how to educate patients?
Yes. I already mentioned that the epiretinal membrane surgery is very basic surgery for retinal surgeon. It's nothing much to do there, just to peel a membrane. But what the benefit you get from this surgery, whether you are dealing with the metamorphopsia, whether you are dealing with the metamorphopsia, whether you are decreasing with the decreased vision, whether it's a consequence of ongoing inflammation. So you should know for what pathology you are dealing the epiretinal membrane. So whether your epiretinal membrane peeling procedure is giving any benefit, because peeling the epiretinal membrane is not of any use of patient. You are treating the VN, you are not treating the epiretinal membrane. So you are not treating the OCT. To see the epiretinal, you had the epiretinal membrane in OCT before surgery. Now you don't have epiretinal membrane in OCT post-operative. Patient doesn't need this one. Patient need the VN. Patient need to get rid of the metamorphopsia. So that's why in the beginning I told that you first look at the pathology, how much the harm the pathology is doing, how much harm your surgery is going to do, and what at the end you can get the results. Because going for 612 VN in a post-uveit eye, doing the epiretinal membrane peel and doing the ILM peel if you want or you don't want. So what benefit that patient will get? He will get 636 VN. So patient underwent the surgery, you did the great surgery, you peel the ear and everything is good, but the patient lost the VN. So what's the benefit? So this is very important, this pathology of retina.
Exactly. And Dr. Salam, would be one of the awkward complications of ERM peeling is the post-operative macular edema. Is there any way to that you might suspect, or is it avoidable? How would you treat this? Then I will listen to George regarding the same question.
I think this is a great question. I think first, less is more. So I think the less you stay in the eye, the less manipulations, I think that decreases the risk of macular edema. This is like anecdotal thinking, at least from my side. The other thing, I treat them usually with topical steroids ocular. If it doesn't remit, then I give them in 3 weeks. I give them orbital fluor. It doesn't remit, then I give them intravitreal Kinalog or Ozurdex. That's what I do.
George, what do you think about the post-vitrectomy macular edema after ERM?
I agree, Dr. Salam. Actually, when you have anatomically so bad, when there's so many disruptions inside the retina, probably going to have the macular edema. And I try at first using drops like steroids or non-steroids, but many cases I use Ozurdex and does improve the edema. But sometimes even when you get better the macular edema, the vision does not improve too much. It's just 1 or 2 lines, just because the anatomical disruptions inside the retina is too much. And even if you get better from the edema, the patient will not improve too much the vision.
Thank you, George. Thank you very much. Thank you, Dr. Hussein, for a nice presentation. I think for the sake of time, we would go straight to Dr. Salam for his presentation.
Well, thank you so much. Yes. So I modified my presentation a little bit based on how things are going with the discussion. So, sorry, not lost. Yeah. So I'll do a very quick run through on what I do for drop nucleus. And then I just want to touch on endophthalmitis and maybe just have a few minutes open the discussion again on endophthalmitis. I think it's a very important topic and might be really important on how we drop the IOL. So let me share my screen. Can you see my screen?
Yes, yes, we can.
Okay, well, thank you so much for the invitation, Dr. Mohammed Al Amri and Dr. Mohammed Awdallah as well. And I'm really glad to be speaking here in the Yemen Society. Actually, I've been in Yemen in 2004, just after I finished my being like an assistant lecturer. So maybe like 5 years after residency, I shared into in a surgical camp, and it was fantastic. I learned a lot and it was a great experience. So I'm glad to be here again, at least virtually. So so for the anterior segment surgeon, what do you do when you have a dropped nucleus? I think not much, just enjoy the moment. And it's something that happens. This is a patient post vitrectomy and a white cataract 2 weeks after vitrectomy. Then you know that this is going to happen. So, and here I think it's a moment of denial. That's me here. This is like many years back. This video you can tell from the quality. And I was thinking maybe the nucleus just shifted to the side, but it's not. So, and the message is don't do like me here. I think stop, put viscoelastic, then come out in a more civilized way. I think the important message for anterior segment surgeons hearing us: do not fish in the vitreous gel. This is an interesting case that was operated next door. The surgeon had a dropped nucleus, and then what happened is that they said, okay, can you do vitrectomy? And I said, fine. And I went and I spoke with the patient, and we just wheeled him in my room. And that's what we found. We found a giant retinal break with the dropped nucleus, probably indicating some fishing that went on. So usually those patients, they do very well. We published recently on their outcome, and they don't do so bad at all. But that's, I think, provided if you just stop, clean the anterior segment, and don't do any fishing, and just remove that case to the posterior segment surgeon. And there's a paper that came out recently showing even if surgery gets delayed for 14 weeks, that's not very much disadvantaging the patient. If you can do it first day or second day, fine. But if the cornea does not permit, or there's no VR surgeon, then delaying the surgery is not that bad for dropped nucleus. So here, this is like the ideal case for dropped nucleus. You've cleaned the vitreous, no cortex, and that's very important. You've put a lens in the sulcus, you suture the wound, and then you refer to a retina surgeon. This is the best situation for dropped nucleus. This is the VR surgeon dream. Okay, so for the posterior segment surgeon, what do we do? The first question is, what size of nuclear fragment can be left in the vitreous cavity? And maybe Dr. Abdullah, if you want to ask the panel for this, maybe if you tell us what you feel. So like there's a quadrant, or like half a quadrant. Would you leave that in the vitreous?
I wouldn't, but I wouldn't, especially if it, I'm sure it is a nuclear fragment of the nucleus.
George?
Nucleus, not a cortex. What do you think, George?
Pardon? You said if I leave some part of the cataract inside the eye, I usually remove everything, but if the patients come with a small piece for a long time with no inflammation, I just observe. But it's pretty much rare. It's not something that's I do want to do. I just want to remove everything.
Yeah, and that's my experience as well. My experience that these eyes do not settle down with anything in the vitreous, and those eyes usually inflamed, have high pressure, grumbling inflammation. I try to not be very much pro-surgery in anything, but I think these eyes do not settle down. And the important message is we'll always clean the cortex very well in these eyes, because that's another reason why these eyes do not settle down after surgery. So I'll show you an example here. I'll spread through that. So this patient was dropped nucleus. When I got the patient in the room, the lens just floated up. So here, what I did is I just went from the back and pushed it up a little bit. And then I went and enlarged the wound and got the lens out. And that was an easy one. Here, something that works, epi-sugar cane works if your pupil gets smaller. And that's the nuclear fragments. If it's soft, you can finish with a cutter. And decreasing the cut rate helps a lot. So if you see here, we're actually decreasing the cut rate, and that helps a lot, because if you have a high cut rate, it just doesn't work very well. And then you go on, and if you have good sulcus support, you can put the lens in the sulcus. And it helps a lot if you capture the lens, because then the lens does not move. Because putting it in the sulcus only, the lens still moves and decenters. Okay, I think I want to show you something what I do. This is how I used to do things like maybe 5 years ago. So I would open the conjunctiva and go with the frag. But I stopped doing this. I don't like the opening of the sclera. I feel it's a big opening. It takes time to open and close. But more important, I think we know that at the era of 20 gauge vitrectomy, we had entry site retinal breaks. So I started doing this where after removing the vitreous, etc., I go actually through the limbus. And it's slightly tricky at the beginning because there's a weird angle of attack. But once you get used to it, it's not difficult at all. And that's what I've been doing in the past 5 years. But then I tell people who refer to me, do not put the lens, because you cannot do that if the lens is in place, if an IOL is in place. And that works so well. But as you can see, there's a slight shift in the view because of the weird angle of attack. So I found that if you, if you use the Kelman tip of the phacoemulsification, so actually what I do now is I use the phaco and not the phacofragmentome, and I use the Kelman tip, and that curve in the Kelman tip corrects for this weird angle and makes things very easy. So that's what I do. I go from the limbus and I use the Kelman tip and I use the phacoemulsification, and it helps if the fragmentome is not there, or if you don't have a fragmentome. It also helps correct that angle. There's a bit of a learning curve for it, but you don't get any wound burn. That does not happen. And that's a picture here. Sorry, I apologize. That's a picture here of after the procedure, and there's no wound burn. I think this is very important, is you have to clean the lens matter very well in the anterior segment as well as in the posterior segment. And this is an example here. You think this is not very much, just leave it. But if you see, there's a lot to retain behind. And of course, search the retina, make sure there's no entry side breaks or any retinal tears or retained lens matter, because again, you have to remove those. And I think that's really what I wanted to show you, just this technique of the limbal entry. And then maybe if we can open the discussion a little bit more on endophthalmitis, if we have a minute. And I just want to show you this slide, which emphasizes the importance of early treatment. I'll just share a slide with you. Yeah.
I think this is a very important subject. So if any of the audience, لو في أحد من الأخوة الحضور يعني يحب إن هو يسأل الدكتور أحمد أو الدكتور جورج regarding this is really important for both anterior and posterior segment surgeons.
السلام عليكم. معلش دكتور نبيل، احنا يعني نقسم الاندوفتالمايتس جريد 1 2 3 4 لما تكون الحاله سيفير، كلاودي كورنيا، ميبرين، كلوزس بيوبل، يمكن فيزلز في البيوبل، وهاي بالبسكان بيعطيك فول اندوفتالمايتس. البيشنت إذا هو light perception and more, we do operation for him immediately. لكن يكون بروجنوز سيء للأسف، لأنه صاير عندهم حاجة ما اسمها سيكليتيك ميبرين حول السيروبروسيس، وهذا بعد ذلك بيعطينا نتائج من ناحية النظر ليست جيدة. ممكن نحافظ على العين. في هذه المرحلة أحقن سيليكون في الحالات هذه، واحيانا نحقن انتيبيوتيك فوق السيليكون. جريد 3 هذا يعني يكون الهوب مور، يعني لسه بشوف من خلال الكورنيا، بشوف الايريس، لكن كلاودي لا زال الكاتاراكت موجود، والفيترياس بيز هيزي، لكن جريد 3 هنا نفس الشيء، ما انتظرش حاجه اسمها حقن، ابدا على طول العمليه، والهوب هنا اكثر. جريد 2 كورنيا كلير، اقدر اشوف من خلال البيوبل، اشوف الفيترياس، بالفيترياس في السيلز موجوده، المريض بيشوف هاند موفمنت كويس، كاونت فينجر، ممكن هذا ممكن اعطيه حقنه في البدايه، وبعد ذلك اتابعه. اذا حدث استجابه كان بها، لكن اذا لم يستجب في خلال يوم، لانه انا بشبه الاندوفتالمايتس بالحريق، انه حرق لازم انا الحقه، اطفي اللي يمكن اطفيه حتى احافظ على الشيء المتبقي. جريد 1 بيجي لي انه يشتكي انه صار عنده فلوترز وجاي لي بدري، هنا اعمل له الحقنه واعطيه المتابعه واخذ وقتي معه. هكذا التقسيم اللي امشي عليه. في اليمن للاسف يوصلني المريض جريد 3 جريد 4. لهذا انا ما عملتش حاجه اسمها ان نعطي حقن، انا اعطيه الديسيشن في العمليه مع الشرح الواضح كامل. الشيء الذي بيواجهنا بعد ذلك، هل احقن لهم سيليكون ام لا؟ طبعا جريد 4 بحقن سيليكون عشان انا نفسيا اكون مطمئن. بعمل كور فيتروكتومي، وطبعا البي اس اس بيمر. بالنسبه للبي في دي هل اشيله ام لا؟ هنا يتوقف على السيفيريتي اوف ذا تشينجز في الريتنا، لانه يصير عندهم ترومبوفليبايتس شديد وبيكون في ميبرينز. يتوقف على الجروث الموجود والبكتيريا المسببه. بعد ثاني يوم فولو اب بعد العمليه جريد 3 و4 يجي لك ورس، يجي يقول لك مش شايف وانا كمان مش شايف، يقول له انتظر شويه، في خلال كم يوم اسبوع يبدا التحسن بعض الشيء. هذا الطريقه اللي نمشي فيه. للاسف المرضى ما يوصلناش بدري. غالبا المرضى من اندوفتالمايتس في اليمن يجي بعد اصابات، والمشكله الكبيره هي لما تجي الاصابه في الاطفال ويكون بسبب نيدل. طبعا نيدل اندوفتالمايتس كان زمان موجود في باكستان وفي الهند، والان موجود في اليمن، لكن الدول اللي هي زي ما تقول وضعها افضل فهذا يشوفه قليل. هل لديكم استراتيجيه اخرى للتعامل؟ هل تحقنوا في الحالات هذه حتى لو جريد 3 و 4 انتيبيوتيك وتنتظروا لليوم الثاني؟ هل تحقنوا سيليكون في نهايه العمليات ام تخلوه على فلويد؟ وايش كمان ممكن تحقن في الفيترياس وانت خارج؟ هل تحقن سيفتازيديم انترافيتريال ولا ديكساميثازون يعني تريامسيلونون او غير ذلك؟ هذا السؤال موجه لكم، وحتى ناخذ باستراتيجي للعلاج للمرضى. هذا اكزوجينيك. الاندوجينيك حكايه ثانيه، اذا حبينا ندخل فيها فهذا يرجع الفضل لكم، وبكون مشكور لتعاونكم معنا. تفضلوا.
I think Dr. Salam, would you elaborate about I'm for myself, I'm not aware of a certain grading for endophthalmitis. Maybe if you detected early or late, but would you elaborate on your how would you manage a case of suspected, even early case of endophthalmitis?
Yes, no, thank you so much. I'm not aware of this grading, but actually it's a beautiful grading. So I don't know if Dr. Nabil, this is like something he came up with, but it's actually beautiful and summarizes the situation nicely and make it like easy to imagine the case. So I really like it. I think if you're suspecting endophthalmitis, you have to deal with it as endophthalmitis. If you're not sure if it's TAS or endophthalmitis, as Fahd said, there are lots of things you can do, especially if the vitreous is not involved. You can give them lots of steroids, see them in 6 hours. Usually anti-chamber reaction gets better if it's TAS, then or endophthalmitis will get worse. As for treatment of endophthalmitis, let's focus on the post-procedure, because there's no evidence to re-advise well about post-trauma. So if we focus on post-procedure, I would suggest at all cases to give intravitreal injection first, because you need antibiotics even if you're going to do surgery. Surgery is not the cure, it's the antibiotics. Surgery is still an adjuvant. And then if the patient is not responding and you can argue 24 or 48 hours, usually you wait a little bit till about 48 hours, then another thing needs to happen. And that can be surgery. You had time to schedule surgery to arrange everything. As for how surgery can be aggressive, I would strongly advise against aggressive surgery endophthalmitis. All what you need is one tear and the eye is lost. If you can compare oil with antibiotics, oil is only bacteriostatic, which means like it's not even doesn't kill the organism, while the antibiotic is super minimum inhibitory concentration level, which is really very strong. So I usually don't use oil unless a detachment happens on table and there's scarring and I cannot clean around it. So that I would use oil. Otherwise, I would close on air. And at the end, from the last trocar, I would put the antibiotics. So I remove all the trocar, last trocar is there. I would just inject the antibiotic. I think vancomycin, ceftazidime, I may or may not inject dexamethasone. But I don't use oil and no aggressive dissection.
Great speaking about the surgery of endophthalmites, and I'm not sure, George, if you understand this question regarding would you prefer to use silicone oil or gas at the end of surgery after endophthalmites. What's your preference? And would you go aggressive? I mean, would you insist on peeling a posterior hyaloid in an endophthalmitis case? Would you do this, George?
The vitrectomy in endophthalmitis is something very tricky. As Salam said, we can lose the eye very easy. And I used to focus on to clean the core of the vitreous. I don't use to spend too much time to take out the posterior hyaloid, because sometimes when you're doing this, the retina is so fragile that gonna cause breaks and you can lose the eye. And then I'm just cleaning all the material that has toxic exudation and bacteria, and just leave with antibiotics. Sometimes I just leave with air, not gas, anything. If you have a break, I do use oil, and we have some study that suggests that oil can be bacteriostatic because bacteria don't grow inside the oil. But I agree with the colleagues that the main important thing to inject antibiotic. I use vancomycin and ceftazidime, and sometimes I use moxifloxacin oral, the adjuvant antibiotic, because 48 hours after we start the oral moxifloxacin, we have some level inside the vitreous. But vitrectomy, don't use for all case, just only for the really bad case. If the patient has 20, 60, 20, 100, just inject and do tap biopsy, just that.
And if you have, George, if you have a case, a complicated cataract case with vitreous prolapse, dropped nucleus, and the patient coming to you next day, and you are, how would you differentiate if it is infectious or non-just reaction to the remaining lens matter? Well, what's your policy? Tell us about it.
I have to check many symptoms. The first one is 24 hours is pretty much rare to be bacteria. The bacteria are gonna be at least 2 days after the surgery, usually to be 3 to 7 days. If you get a bad inflammation with hypopia and everything, 24 hours after your cataract probably is a test, not any infection. But if you have very bad, I just want to clean this as fast, because the inflammation, high pressure, everything gonna damage the eye. And if you can't, it's emergency. We have to operate this case at least in 48 hours, not just postpone.
Do you put some weight on the patient pain and the tenderness on the globe next, when you see next day? Is there some difference, or you do what as Dr. Salam did, doing a lot of steroids for 6 hours and recheck the patient?
I used to try steroid for 6 hours and check the patient and see if they respond anything. If don't respond anything, I start to think about endophthalmitis. But as I said, with 24 hours, I never seen one case that's so fast with bacteria.
Okay, great. أي أسئلة من الإخوة الحضور؟
Did you deal with needling endophthalmitis in children? By needle endophthalmitis in children, did you deal
trauma? You mean penetrating trauma, or
this is needle by needle endophthalmitis? Because our children, they are playing with everything, also the needle. So
so trauma is different. You're absolutely right. Penetrating trauma is different. The Bacillus cereus is a very high, it's common, and it's a very bad organism. I think, again, as Dr. Abdullah said in a very nice way, arrange vitrectomy, but the problem is it takes time, even in best centers, because, for example, you'll be doing elective surgery, and that happened to me in England several times. So we're doing a list of vitrectomy surgery. Then this patient came with endophthalmitis. So I went and I told them, let's do this patient. And the nurses would say, no, this is not a sterile case. We need to do the sterile cases first. Then infection disease on board. I'm telling them, this is it's not going to infect the other cases. No. So the case waits 7 hours to be done. And then the patient of this lady, the daughter of this lady is telling me, you kept telling us this is urgent and we waited 7 hours. And I'm sure this happens everywhere. If you get an infection patient and you want to do her now, they will say you have to finish the other cases first. So I think, logistics. So I would inject this patient quickly and then get the patient to the operating room. If the eye is open and you cannot inject, that's something else. That's what I would suggest.
Okay, great. I think we'll go to the next presentation. George, you can share your screen right now. Then I will do my presentation last.
I just brought a case, not complete presentation, just discuss. Can you see my slide?
Yes, we can see it well.
Okay, I'd like to thank you all to invite me to this very distinguished meeting. It's a tremendous privilege to be among you, and the first time in the Yemen Ophthalmology Society. I really want to, in the future, meet everyone in person and exchange ideas, make friendship. Thank you so much for inviting me for the first time here, and have not disclosed concerning this topic. And I would like to present just a case. Maybe we're going to combine everything we are discussing here about trauma and ophthalmitis and everything. It's a trauma case, a 52-year-old male with 6-day trauma in OD after working with a hammer. He presents with LP vision in this eye, and the ultrasound showed me vitreous hemorrhage and metallic interforeign body in the past planar position. And then this was a very short surgery. And after that, we're going to discuss all the topics. Just try to clean all the vitreous base and all the hemorrhage before try to remove the metallic foreign body. It's very important to clean meticulously the vitreous base, because sometimes you can find small tears or even big tear, and we need to treat this lesion. And I tried to use magnetic to remove this piece of material. This patient has already the intraocular lens, and I try to remove by the past planar. It's not something that I do use frequently, just because it's more have more dangers for the retina, trying to open a large opening in the sclera. But this case I tried, and I was very successfully to remove this. And just suture all the sclera and check the vitreous base, because sometimes when you are removing we're gonna have breaks in the retina. And then the comment is the best approach to remove intraocular foreign body. In this case, I use the sclerotomy, but for me, it's the best thing to do is try to remove that anterior chamber, just to make a hole in the posterior capsule, and it's gonna be less traumatic for the eye to try by the anterior chamber. This case, the patient has already the lens in place, and then I try by sclera. And how to prevent retinal detachment. One thing is to clean very well the vitreous base and try to check even before and after to remove the intraocular flowing body or the retina, because sometimes when you attempt to remove the intraocular flowing body, the vitreous that come up inside the sclerotomy gonna trash out the retina and make tears, and we need to treat right away. And how to prevent endophthalmitis. When you have metallic material or glasses, I don't use to inject any antibiotic at the end of surgery, but to have any organic material like wood or any other thing, I finish with antibiotic, because it's very frequently bacillus, and bacillus destroy the eyes so fast, and then I don't have a chance to save the eye, and then I finish the surgery with antibiotic. But I think it's open for discussion.
Thank you, George, for your nice presentation. Any questions from the audience to Dr. George about the trauma and intraocular foreign bodies?
Yes. During we're in Yemen, we have a lot of foreign bodies, and we deal with all foreign bodies as endophthalmitis in the same time. So when we start the operation, this case will be last case in operator theater, and we fluid with antibiotics. This is mandatory, and we start to deal with this case. About how to remove the foreign body, I prefer to remove it from the anterior segment through posterior cataract, lensectomy, posterior capsulotomy, and removal from the anterior. Two types of the foreign body. Inert foreign body is glasses or like that. If it is not damaged, the patient see well, it's preferred to leave it if the vision is good. But metallic foreign body, this is mandatory to do abrasion, and we are going from the anterior to posterior. To remove the foreign body from the sclera, my experience, I don't like it, because and sometimes I have retinal detachment or something else. I don't like it, so I prefer to remove from the anterior. This is my way in these cases.
Okay,
I agree
great.
completely. Everything you said. It's my preference as well is to take it out by the anterior chamber, because it's more safety. And when you're removed for sclera, many times we can have retinal detachment. Because of that, we need to finish the case, recheck all the vitreous base, and treat any tears you have done by the extraction of the intraocular fluid body. And glass, if it was a small piece of glass, of course, we don't need to remove, because glass is inert. We don't make any difference, but metal, you do need to remove, because it's gonna destroy the eye in few months.
Great. Any other questions from the audience or comments? Dr. Nabil, we have one. Okay, تفضل.
One question.
I have questions about drop nucleus. It's a mandatory to do BVD, or we can do only just core vitrectomy and release vitreous around the drop nucleus?
In what cases, doctor?
Drop nucleus. Drop nucleus.
Okay. Dr. Salam, did you get the question?
Ahmed Salam Kisi.
Yes. So I try to induce PVD and remove all the vitreous before removing the lens. Having said that, there are cases actually where I was not able to do PVD. And I think I just go with what I try to think, okay, what shall I do here? And I try several times, I cannot remove it. I think that's it, I will leave it. But if I can remove it, I will remove it. But very important, as George was saying, in trauma or drop nucleus, to check the retina carefully in the periphery, make sure there are no breaks. I'm not very aggressive removing the vitreous base in anything except anterior PVR, but just make sure there are no tears there. Because if you find a tear there, it's very easy to treat and leave gas, and the patient should do very well.
Okay, Dr. Excuse me. My way in this case is, if you have hard nucleus, I prefer to use BFC to elevate the nucleus and remove it from the anterior. But if it is fragment, I can remove it. So by ocultum, if it is a nucleus but it is not hard, I'm using the phaco tip from the after vitrectomy. I'm using phaco tip and finish like that. This is my way in this situation.
Very nice.
Okay, thank you, Dr. Nabil, very much. I think we can move to the last presentation. I prepared one I can share for pars plana vitrectomy in rhegmatogenous retinal detachment. So can you see my screen? Is anybody can see my screen shared?
Yes.
Yes, everything is okay.
Okay, great. So my
I think Dr. Abdallah pressed the play button, so that would be, yeah.
Okay. This is better, right?
Yes.
طيب اوكي. السلام عليكم ورحمة الله. طبعا ألف شكر للدكتور محمد العمري والإخوة الأطباء المحترمين في الجمعية اليمنية طب العيون for this invitation. My talk is about tips and tricks in pars plana vitrectomy for rhegmatogenous retinal detachment. I will try to go through this quickly. The objectives and the strategy of when you approach a case of rhegmatogenous retinal detachment. You have to first to remove the traction, then you locate and seal the tears or the breaks. You drain the subretinal fluid, and finally you put a tamponade for some time. And how to achieve these objectives? By complete vitrectomy. And the complete vitrectomy, our strategy goes from doing core vitrectomy, then inducing a posterior vitreous detachment, PVD, and you move to the peripheral vitrectomy. In this sequence, so you achieve complete vitrectomy. This is the strategy in order to achieve the objectives. These are the steps. We'll go through quickly for the steps. And for the machine, we have a lot of sub-modes on the machine, but this is my preference in if you are using the Constellation machine, but again, you can adjust this in all machines. I have been using a lot of sub-modes, and this is what I finally use in most of the cases. I just set the cutting rate at a high and throughout the procedure. I don't change. Then I utilize the vacuum as needed in a linear way, as we can see there. But we can discuss with the panelists later about their preferential or preferred pattern in setting up the machine. But this is the I found the most pragmatic and most useful in most cases of tackling the rhegmatogenous retinal detachment. You start first with the core vitrectomy, and as I said, as I mentioned, this high cutting, or you set it on the core mode of the machine where you have a maximum port open duty cycle with a relatively high vacuum. You ensure first when you enter the eye, you ensure a good blood flow by watching the optic nerve. This is really important. You don't want to have pulsating retinal vessels when you enter, so you adjust the blood flow. You visualize the cutting port at all times. You start in the middle, and you allow vitreous to flow to the probe first. Then when vitreous stops flowing, you can advance laterally to remove more of the vitreous skirt or around, and you are done with this. You move posteriorly. In this way, you finish with core vitrectomy and you go posteriorly to the next step. While you are in the eye, you avoid excessive movement of the instrument. I will show here the next step when you go posterior, when peeling posterior hyaloid, and I will go quickly through methods of peeling posterior hyaloid. After you stain the vitreous with Kenacort or triamcinolone, the PV induction using the probe suction is the most common way, where you suck on the posterior hyaloid at the disc or slightly nasal over the disc or nasal to the disc. And as you can see here, we are have elevated with the occutome the posterior vitreous, and we start cutting it. Maybe another method is to use the Thanos scraper to create a hole in the posterior hyaloid. You widen the hole, then you elevate it using the probe. This is another method of dealing or peeling the posterior hyaloid. Sometimes with a very strong attachment, you can use a forceps even at the optic disc, where you hold the posterior vitreous and you just elevate it with the forceps. Sometimes you might need this. At times, you find the posterior vitreous is already detached. You have to make sure of this. And sometimes with some vitreous remnant is removed carefully from the macula, and you get a very clean posterior vitreous detachment. Next, what I do, I like to use the PFCL injection over the optic disc in a single bubble, where you inject into the PFCL to avoid fish eggs, as in this case. When you inject away from the bubble, you get a lot of small bubbles, and this creates a risk of of the PFCL migrating under a retinal tear. The value of PFCL is stabilization of the retina and displacement of the subretinal fluid anteriorly, so you can get more stable retina, and you do a more stable vitrectomy of the periphery with the aim to achieve complete vitrectomy, as we have said. The next step is you identify and mark the retinal tears. Here you, with some clear indentation, it helps to identify, as here you can see the break we identified with the indentation, and you remove all the vitreous around the tear. I usually remove the flap of the tear because it's some traction on this flap, and essentially I convert the tear, the horseshoe, into a hole. More PFCL injection in order to squeeze the subretinal fluid anteriorly, and you start draining. If you have some traction on the tear, you might want to do some retinectomy on the rolled edge after you're doing diathermy, in order to allow for removal of this PVR. Sometimes you can get some bleeding. You treat with endodiathermy, and also endodiathermy is very important to mark the tear in order to be able to visualize it later after air injection or under to do laser later on. So after we identified, we go especially in PVR cases for shaving of the vitreous space, and here you have to utilize the shaving mode where the maximum port closed duty cycle with a low vacuum. As I can see, you can move on the retina all the way, shaving the posterior hyaloid, especially around the recognized tear, with this setting of very high, the highest cutting rate and the low vacuum rate. Finally, I usually do the laser under PFCL as we can see here, or you can do it under air. And finally, you get to drain the subretinal fluid and flatten with the fluid air exchange. If you didn't use PFCL or PFCL air exchange. Here there is a trick on while there is this is the PFCL filled eye. When you inject the air, you try to dry the fluid around the skirt, all around the PFCL bubble, while before moving to the central area, and you drain over the break. This is important in order to avoid displacement of fluid posteriorly while you are removing the PFCL. Here, after good drying of the periphery, and you move to the optic nerve, and you can remove the PFCL over the optic disc, and to obtain a air-filled globe. If you want to put silicone, you can decrease the pressure, reduce, or you can move to if you don't prefer to use silicone, you can use either sulfur hexafluoride, or even leave air if you are sure that there was no significant PVR. Thank you very much. If any of the panelists would like to comment or.
It's a great presentation, Dr. Abdallah. Really beautiful, and you covered all the important points.
Salam. معلش. We will do the same procedure, but I am using at the end when the BFC cover the hole or the break, I change to the air and doing sheathing under the air. Did you like that? Sheathing under the air. Did you
can do this, yes.
You understand me?
So you put air first, and you fill the globe. In this way, you can detect traction, for example, will be going to be highlighted under air.
Yes, and also sheathing the vitreous base under the air.
Okay.
After that, we will do like and change air fluid exchange and BFC and inject the silicone in the cases. But I want to ask, who and when you prefer silicone or gas in these cases? Gas or
if there is no PVR, I usually use gas, and I prefer to use gas, sulfur hexafluoride, or even air. I'm not inclined to use silicone oil much. Silicone oil induces PVR itself if left in the eye, unless there is PVRC, for example, and you need longer tamponade. I would use silicone. What do you think, Dr. Salam?
Yeah, I agree. I try to keep primary retinal detachment surgery very simple. So at first, usually the eyes I operate on have PVD, because the eyes that do not have PVD are patients with atrophic holes or dialysis, and for those patients, I do segmental buccal. I think it's much easier. You don't deal with the problem of inducing PVD, and the results are fantastic. Then the eyes who have PVD, when you have a horseshoe tear, by definition, there is PVD. You can have schizoid in myopic patients, so I always use Kenalog, but usually there's PVD. So what I do is I just go remove the core vitreous, check that there's PVD with Kenalog, remove the core vitreous, and just remove the vitreous around the break, trim the break edge as you did. And then after that, I drain from the break. I don't use PFCL. I don't drain even the fluid in the vitreous cavity. I drain from the break, then under air, then either laser or cryo. I like to use cryo if it's 1 or 2 tears. It's very quick, very cheap. You don't need to have like real dryness of the edge. Then after that, I just exchange for SF6, a slightly expansile concentration. And I don't drain over the disc because I don't want to shift the fluid. So usually I just keep it very simple. That's what I do.
I totally agree. I don't use I use PFCL most of the time, but because I don't like to use posterior drainage retinotomy. Let's ask George about his strategy in this. Do you prefer to use a PFCL to drain anteriorly through the tear, or you would do a posterior retinotomy?
Nowadays, I use very few PFO, not just because it's expensive, but also because I try to be very simple, and I try to only drain by the tears, and I don't care if I leave a lot of fluid in the macula. If you block the hole, the RPE, you're gonna pump out all the fluid, and if you do this, we're gonna displace less the retina. All the idea about the retina detachment nowadays is not displace the retina, and then PFO is push the retina back to the retina, and this is gonna make the traction for move the retina during the procedure. And then I do use SF6. I use C3FA only if you have situation with PVR and oil. What situation use oil? If the patient has to fly, or if the patient has only one eye and very anxious, not want to wait for the gas gonna absorb, or if you have PVR. If you have PVR, need to do some retinectomy inferior, I do use oil for sure. But for primary vitrectomy, I use most of the time SF6.
What about internal limiting membrane peeling? Is mandatory in all cases? Internal limiting membrane peeling is mandatory in all cases?
I don't do membrane ILM peeling in all cases. Just in the severest cases of PVR, I do ILM peeling, and but as a routine, no, I don't.
I agree. The same. I use only for bad PVR. I don't peel the retina in the primary case anytime.
Can I say something about it?
Sure.
I think, I have a saying about this. I think the best thing to do really with primary retinal detachment is to keep it very simple. In my mind, whatever you would do, the success rate is in the high 80s. If you look at all the big series, the primary success rate is not in the 90s, it's in the high 80s. So whatever you do 360 laser, you do ILM peel, you use PFCL, you do vitreous-based shaving, extensively, you do vitreous-based shaving under air, whatever you're going to do, your success rate is going to be in the high 80s. So I think just keep it simple, easy, try to avoid displacement by thinking which position might be best for the patient direct after the surgery, and I would just keep it simple. That's my my thinking.
I can't agree more, Dr. Salam. Less is more, as
less is more.
The saying says, and I mean there is a lot of ways to do vitrectomy, keeping it simple. You have also a lot of tools in your armamentarium. And you do the customized surgery according to the case you have. Let's talk about the machine setting. Let's talk a little about the machine setting. For me, as I said, I prefer to set a constant cutting rate, and I change the vacuum. What is your setting, George?
It's quite the same. I use high rate cutting, and I try to make the safe by the foot pedal. I use everything is set in the machine. For example, I use more around 400 millimeter mercury in the vacuum, and around 5,000 to 7,000 cut rates. And then I just, if the retina is too mobile, I just push less the vacuum to go more slowly the vitrectomy. It depends.
Adjust the vacuum according to the cases.
Yeah.
Yeah, just the vacuum, because I found some settings are more confusing, like the 3D or something. What do you think, Dr. Salam?
Yeah, no, I agree. I do exactly like you. I use the vitreous-based shaping mode only if the retina is too mobile, because you want to decrease like you just want to give yourself a buffer. But there's a very nice paper out by David Steele that showed the more you're like open, like you're more open, the more it's like continuous flow and less stress on the retina. So I do exactly like you.
Okay, great. Dr. Nabil, any question from the audience or from yourself, or any comments you would like to add?
Yes, about the machine, core vitrectomy, high vacuum and the high rate of the vitrectomy. And when we move to the more periphery, I prefer to put BFCL and start with low vacuum and high rate of vitrectomy. This is my way in these cases.
Okay, great. Any of the audience has any comment or
أي سؤال شباب؟ يبدو أن نحن مع بعض.
شكرا دكتور نبيل للدعوة الكريمة again we are thankful to Dr. Al Amri and to the Yemeni Ophthalmology Society for the opportunity to share medical and surgical cases, and we'll go back to Dr. Al Amri.
Thank you very much, Dr. Mohammed Al for this moderation and presentation as usual. All thank you for Dr. George and Dr. Salam and Professor Hussein. It was a very interesting, I think, and thank you, Dr. Nabil, for the this intervention and discussion. Very nice. At the end, I would like to thank you all. I'd like to thank Yemeni Ophthalmic Society, all my dear friends there, and all the members of the executive committee for collaboration between Yemeni Ophthalmic Society and MEOM Academy. And I hope that you enjoy. I know we take a lot of time, but we feel that we are the last session, so we can have, maybe, I don't know if you are the last sessions or not, but we take a lot of time. I hope that you enjoy and it was beneficial for you. I'd like to thank George. He is a very friend of mine and Brazil, and it is first time also to be seen here in the Middle East with us. So thank you, Salam. As usual, you are one of the pioneer eminent. Abdullah, my dearest friend, and thanks for Dr. Mahfouz and all the team of the executive committee. And we hope to see inshallah tomorrow with other session. It will be about anterior segment cataract in cataract sessions.
شكرا عشاء دكتور محمد. في عشاء بتاع الميتنج.
في عشاء we will send inshallah by Zoom. By Zoom we will send you all.
I was saying, George, there is no dinner. We were expecting a dinner.
عشاء يمني بقى.
عشاء
بنحبه.
العشاء اليمني عاوز معناته لحم صغار وحاجه انت ما تعرفهاش.
هنرسل لكم. شكرا جزيلا لكم جميعا. شكرا دكتور محمد، شكرا دكتور سلام، شكرا جميعا لكم، ونشوفكم ان شاء الله قريبا في مؤتمر مصر باذن الله، ونلتقي على خير. الف شكر للجميع. Thank you very much for all of us. مع السلامه، نشوفكم على خير. مع السلامه.
Thank you so much for everything.
Thank you.